Thanks for all attendees. Thanks for the speakers. Thanks for the chairpersons for accepting our invitations. And let's start our last show today. It will be an interactive chest cases. It's a real life cases collected from my side in Ain Shams University and private places, and also my colleague, Dr. Youssef. To be more and more beneficial, I will need your participation in this session. Let's start by the second case until Dr. Youssef came. This is a female patient, 52 years old, with a progressive dyspnea, with a medical history of chronic bowel disorder. Came for CT chest without contrast, and this is the CT chest mediastinal and lung window. Anybody can help me in this case? Any volunteer? Chest cases is very easy. You will not be completely wrong, so trust in your opinion. Anyone?
في higher lymph nodes شك في sarcoidosis.
Okay, it's better to judge on lymph nodes by non-contrast CT. It will be you will be non-confident of the finding. Okay, let's. Anybody?
Cardiomegaly and ground glass opacity in the lungs. This may specify lung congestion.
Cardiomegaly?
Yes,
okay.
Pulmonary artery prominency or
okay.
ground glass opacities.
Okay, we have a cardiomegaly, some sort of pulmonary congestion, and?
A cellular lesion in the right breast.
Okay, this is good. We have a right breast suspicious lesion also. And we have what's called pulmonary mosaic attenuation of the lung. We have an areas of ground glassing, whitish area, ground glassing area, alternating with a blackish or normal lung or areas of air trapping, and this is what's called pulmonary mosaic attenuation. So we have three sure findings. We have a cardiomegaly, we have a pulmonary mosaic attenuations, and we have, unfortunately, a right breast speculated suspicious mass lesion. How we can deal with a case of pulmonary mosaic attenuation? We have a lot of differential diagnoses in such cases, pulmonary mosaic attenuation. So we must have an algorithm to deal with the pulmonary mosaic attenuation. First of all, you must look for the blood vessels, even it's not non-contrast study. Look to the caliber of the blood vessels in the areas of ground glassing and the areas of air trapping. If they are not equal in caliber, such in this case, there is an equal caliber for the blood vessels between the ground glassing area and areas of air trapping, so we have deal with a case of chronic pulmonary embolism or a vascular case. If they are equal in caliber between the areas of ground glassing and the areas of air trapping, so we are dealing with either a hypersensitivity pneumonitis if there is an upper lobar predominance, and if there is lower lobar predominance, we are dealing with a small airway disease or bronchiolitis obliterans as an interstitial lung disease, or idiopathic, even post-infectious, and there is a strong association between bronchiolitis obliterans and the irritable bowel disease. And if we have a look backward, this case was a history of bowel disorder, so we deal with a case of bronchiolitis obliterans. Another key point, we must have a checklist during dealing with a CT chest or even any CT, you must put a checklist for yourself. This is a good notice for breast cancer on the right side of the breast, because this is a checklist. We must see the lung window, the mediastinal window, the mediastinum, the lymph node, the heart, the vessels. Don't forget the reps, don't forget the vertebral column, don't forget the breast back muscles, don't forget the tracheobronchial tree. Dr. Maram take a long lecture for tracheobronchial tree, so you must put a long checklist. Don't forget the thyroid and lower neck. A lot of people came with chronic dyspnea and repeated chest X-ray, and repeated CT chest and normal case, okay? And we just forget there is a multinodular goiter and this is the cause of dyspnea, okay? And don't forget the upper abdominal cuts.
تمام.
Dr. Yusuf.
Thanks for yeah. We start first by this case, 60-year-old male patient with chronic cough. This is the X-ray chest of this patient, and this is the CT scan. What we see? Could you share? What?
Dr. Yusuf.
No. Yes. Yes.
There is bilateral areas of consolidation with air bronchogram.
Yes.
And tree-in-bud appearance and bronchiectasis. And I think bronchial wall thickening.
CT? What CT add to you?
I am talking about CT.
Consolidation and what? Tree-in-bud?
Bronchiectasis. There is an area, I don't know if it's of cavitation or cystic lesion. I don't know it is connected to the bronchi or not.
Yes, very good. Very good. This is what want I see. The chest X-ray, as we see, we have multiple patchy areas of consolidation, more evident in right upper lobe, as you see. The CT added to us, there is patchy consolidation and cavity. You see the cavity? Cavitation in the right upper lobe. 60-year-old man with consolidation, patchy consolidation and cavitation, you should suspect. You should suspect consolidation, tree-in-bud appearance, cavitation. Yes? Yes? What do you think about active TB?
Cavities in the upper lobes of tree-in-bud.
Yes. Tree-in-bud mean what?
Endobronchial.
Yes, endobronchial spread. But you said this is active TB or could be reactivation TB?
I don't see يعني old مفيش fibrosis. مش شايفة fibrosis.
Active or reactivation TB? Active.
مش شايفة sign of old TB.
What signs of old TB?
Fibrosis في
Yes.
upper lobes. Calcification.
Yes.
Calcified lymph nodes.
Volume loss.
Volume
calcified lymph nodes. Yes. It could be reactivation TB.
أنا مش شايفة الأبر لوبس يعني مش شايفة الإيبيكال هنا cuts مش.
Is the cavitation could to be reactivation TB?
Can.
Yes. As we said, chest X-ray shows right upper lobe opacity with air bronchogram. CT added to us to confirm cavitation lesion. The diagnosis is pulmonary TB reactivation TB. I want to ask some questions. How you distinguish imaging features between reactivated TB and carcinoma of the lung? How to differentiate between those possibilities? Who want to say? How you differentiate between reactivation TB and carcinoma of the lung? Yes? Anyone? Anyone? How you can differentiate between reactivation TB and carcinoma of the lung? In simple word, how you differentiate? Who? السايت.
السايتس upper lobes apical
Yes.
أو superior segment of lower lobes.
Yes.
الوول لو الوول بتاع الكافيتس مثلا سيك.
From what you said before, if you see consolidation in upper lobe with cavitation, thick wall cavities, yes, and the three embod meaning endobronchial spread. All of these going to TB. Calcified lymph node going with?
TB.
Yes. Volume loss fibrosis going with? While carcinoma. What about carcinoma?
pathological lymph node يعني ما فيهاش calcification ممكن.
Is the pathological lymph node with carcinoma calcified or none?
كان
Calcify, yes, non-calcifying lymph node is with carcinoma. Also? Spread to what? Spread to what?
liver.
Spread to what? There is difference between spread and metastasis. Spread to what?
lymph node local.
Spread to pleura and chest wall. This is spread. While the metastasis going to?
من liver common يعني.
The first brain. The first metastasis of bronchogenic carcinoma to the brain. Yes. This is the distinguished imaging features between activation TB and carcinoma. Again, upper lobe consolidation with calcified lymph node, cavities, volume loss, all of this with reactivation TB. If you see mass with non-calcified lymph node spread to the pleura or chest wall and the distant metastasis, all of this with carcinoma. Another patient, 45-year-old female with hemoptysis. 45 years old female with hemoptysis. What can you see? "45-year-old female with hemoptysis."
Any volunteer?
Yes?
It's
Anyone?
arrowed already. It's already arrowed.
The arrow pointing to the lesion. Anyone want to share?
Nothing tricky at all.
Yes? Anyone? Yes? Yes? What?
Stenosis trachea.
Stenosis? The arrow pointing to lesion within the bronchus, yes? What you see within the bronchus? Foreign body or what? Foreign body or blood clot? Anything else?
بالنسبه للفاسكولاريتي في سيجمنت كبيره قوي من اللنج ما فيها اوليجيميا شويه ما فيش فيها جود فاسكولاريتي
or atelectasis. You see the atelectasis?
posterior.
Yes, this is atelectasis.
Yes.
Think about this. What is within the bronchus and associated with atelectasis?
ممكن
Some colleagues say foreign body, some colleagues.
obstruction ممكن ميوكاس بلاج او اي حاجه عملت
Others.
برونكاس.
You are on the way. Others.
ما احنا حضرتك بتقول هيموبسيس عشان كده قلت ممكن تكون بلاد كلوت قفلت البرونكاس.
ممكن تكون enhanced lesions.
Yes. What is the differential for enhancing lesion within the bronchus?
What is the commonest tumor inside the bronchus? Endobronchial tumor.
Yes.
What's the commonest?
Others? Other differential? This is well-defined, rounded, enhancing lesion. Well-defined, rounded, enhancing lesion. Huh? Who want to share?
Yes, we have an answer here. Yes.
Where?
مين قال carcinoid? Yes.
Yes.
Carcinoma tumor.
Yes, yes, yes. As we see, the CT chest shows central endobronchial lesion, rounded, well-defined endobronchial lesion with post-obstructive collapse. You see the collapse near the obstruction. The diagnosis is endobronchial carcinoma tumor. My question is, what is the classic contrast enhancement pattern of bronchial carcinoid? What is the classic enhancement pattern of endobronchial carcinoid? What is the contrast enhancement pattern of bronchial carcinoid? I think Dr. Muhammad said.
As we
Yes,
diffuse homogeneous enhancement.
very good, very good. Intense contrast enhancement in the arterial phase because the carcinoid is hyper or hypovascular? Hypervascular. Yes.
Okay, another case of hemopsis. Okay, but this is a male patient. Okay, 60 years old, smoker. Okay, and the patient has a past history of repeated chest infection with greenish sputum and recurrent attack of high-grade fever, and almost he came to the ER with a recurrent attack of hemopsis, and this is the image of one of the attacks came with. It's very easy, nothing tricky. We make a round for all chest diseases today.
Yes.
Bronchiectasis.
Okay, there is a bronchiectasis. Nothing? Nothing else? There is a dilated bronchioles, okay? Bronchiectasis, cystic bronchiectasis, involving most of the lungs. Nothing else? The second image and the lower loops.
The ground glass.
Yes, and yes. Someone dream bud.
Yes.
Okay, so we have three finding here: bronchiectasis, dream bud, and ground glass. And this is the bronchiectasis explaining the chronicity of the patient. The patient is coming with repeated attacks of hemopsis and repeated attacks of infection, high-grade fever, and greenish sputum, and this is mostly explains the chronicity of the patient's complaint. Okay, and regarding the ground glassing, this is maybe an activity of the disease or an site of hemopsis, and this is maybe very important if this patient is going to interventional if the hemopsis is life-saving in this case. And the ground glassing may alarm, this is maybe the sites of hemorrhage. This is hemorrhage, okay? And the dream bud appearance, we have two explanations for the dream bud appearance. This may be what's called bronchiolexis. The dilatation of the small bronchioles appears as a dream bud appearance, or maybe a superadded fungal infection, which is very easy in such case with bronchiectasis. And this is the mediastinal window, which is very important to unify the protocol for the patient with hemopsis. We must not only depending on the non-contrast CT chest, but we must also add a CT pulmonary angio because pulmonary embolism is one of the cases, one of the causes of hemopsis, and we must do what's called bronchial angiography. الرجعة بتاعت البلمونري انجيو. Okay, to pacify the aorta and to detect the bronchial collaterals, which is the cause of hemopsis. And this is what's called broad mapping for the intervention radiologist to very easily go to the bronchial arteries, which is always arising from the descending thoracic aorta. A very easy clue, we have no branches from the descending thoracic aorta. So if we find and if you see any branching arising from the descending thoracic aorta, this is a pathological bronchial artery. And this is a life-saving for the patients if it is included by the intervention radiologist. So we must unify the protocol for the case of hemopsis, as we said, non-contrast, pulmonary angio, and what's called bronchial angio or aortography to detect the site of hemorrhage, the cause of the hemopsis, and to detect what's called bronchial collaterals if he's going to interventional occlusion.
Another patient, 70-year-old male with dyspnea. This is the CT chest cuts. 70-year-old patient with dyspnea.
في bilateral reticulations وبasal honeycombing, mild honeycombing. Diagnosis UIB.
Yes. Again, as we see, we have basal subpleural honeycombing reticulations. The predominant sign here is honeycombing. Yes, in basal and subpleural location. High resolution CT shows peripheral reticulations, honeycombing, and traction bronchiectasis. This is the idiopathic pulmonary fibrosis UIB pattern. My questions is, how you differentiate between UIB from the NSIB on high resolution CT? As we said now, the UIB is characterized by honeycombing, subpleural location. How you differentiate between UIB and NSIP on high resolution CT?
Usual interstitial pneumonia and non-specific interstitial pneumonia.
Yes.
And these are the two most common forms of idiopathic interstitial pulmonary fibrosis.
How you differentiate?
Is there any clue?
As we said, the imaging clue for UIB is subpleural location, honeycombing. What is the clue for the non-specific interstitial pneumonitis? What? Yes.
NSIP is more central than subpleural?
Could I add something?
Yes. NSIP is
yes.
more central. It's not subpleural. Usually.
Very bronchovascular.
Yes,
yes.
bronchivascular.
Yes.
And the absence of fibrosis except the fibrotic type. NSIP has fibrotic type and non-fibrotic type. The fibrosis is more common with UIP.
As we said, the main pathology or main radiological here in UIB is honeycombing.
Yes.
What is the main in the NSIB?
Ground glass.
Yes.
Yes.
Yes. Ground glass.
Thank you.
Notes, a very small notes, is the honeycombing. All of us know honeycombing is very characteristic for UIB.
Yeah.
Okay? But when we see a widespread, extensive pulmonary fibrosis with honeycombing, still you are confident of UIB? In this case, it's very characteristic, bilateral, lower lobar, peripheral honeycombing. If we see extensive widespread pulmonary fibrosis and upper and lower honeycombing, you are still confident of UIB? No. Any interstitial pulmonary fibrosis end by extensive pulmonary fibrosis and honeycombing. Hypersensitivity pneumonitis, non-specific interstitial, UIB, any type of interstitial lung disease at the end stage end by extensive widespread pulmonary fibrosis and UIB. That's why you must answer for the chest clinician. If the patient came for in a late stage, you cannot classify the subtype. We can classify it early as we can. If the patient come early, we can classify the peripheral dominance, central dominance. The honeycombing is characteristic, but the end stage of all almost the same. This is a complicated, complex case. It's a male patient, rheumatoid arthritis patient, came with dyspnea and cough. It's almost the same, nothing tricky. Bilateral? Yes.
bilateral honeycombing basal هي ممكن بقى يبقى idiopathic يبقى secondary UIB.
So we have an idiopathic type of UIB, and we have the second most common is rheumatoid arthritis or even connective tissue or collagen disease induced
UIB.
usual interstitial pneumonia. Okay, with me? This is the same case, and we already finalized it, and we are sure of the diagnosis of UIB. Okay, came with you, follow up, yet with fever, dyspnea, okay, and unusual cough, even productive. And this is the follow-up CT.
secondary infection.
Why?
وانا مش شايفه sign of infection يعني في
الانسر كانت في الكيس اللي فاتت على فكره.
نعم.
الانسر كانت في الكيس اللي فاتت على طول. Yes. We have a new CT finding, which is ground glass. And ground glass is not a finding of UIB. So, mostly with the clinical picture of the patients, fever, cough, greenish sputum, or even productive sputum, not the usual. So, the ground glass is almost explained an underlying infection, which is mostly viral infection. Ground glass بيحب الviral. Okay. If the patient is not febrile and not symptomatic, what's your explanation of the ground glass?
هو ممكن الاميونيتي بتاعته تبقى حاجه الاميونيتي واقعه يعني not febrile.
Any yes, just came for follow-up. Maybe complaining of increasing the degree of dyspnea.
لو هو جالي اول مره كده ممكن.
No, we have a case already established UIB case. In such case, what is the explanation of ground glass? Any answer? Air trapping, not ground glassing. يبقى blackish, مش whitish. Activity of the disease. Any activity of fibrosis presented first by ground glass.
activity of disease.
Activity of fibrosis. Activity of UIB.
لا معلومه جديده.
Okay, this is the same case, okay, in the same setting, okay. He admitted to the hospital and not improved with medical treatment and even deteriorated and desaturated and enter ICU and oxygen therapy. And of course, the chest clinician searched for another reason for the desaturation and not responding to the treatment and repeat the CT again, right? And almost
the same. Yeah,
the same. What's your recommendation for the chest clinician in this case?
هو ممكن يكون في secondary pulmonary hypertension مثلا. Secondary pulmonary hypertension.
Hypertension? Acute?
لا مش acute ما يبقاش acute.
And suddenly desaturated. عيان عنده
pulmonary embolus.
Yes.
وخاصة العيان عنده rheumatoid arthritis. Okay. وviral infection. Maybe COVID. عنده 2 risk factor for pulmonary embolism, and this was the case. A pulmonary embolism. So you must think of pulmonary embolism when the patient is resistant for the treatment and follow-up CT is normal in patients with infection, mostly viral, and we have a lot of history with COVID, okay? And if have another precipitating factor as rheumatoid arthritis, which is risky for pulmonary embolism, you must think of pulmonary embolism.
Yes, yes, yes. 50-year-old female patient with chest pain. 50-year-old female patient with chest pain. This, yes. Pulmonary vein thrombosis.